Welcome to the Reimagine Healthcare podcast. I'm your host, Noah Voles. Over the past episode, we followed one Southern Oregon family through their 2024 health insurance year. We watched them delay care, deplete savings, accumulate debt, and make impossible choices between healthcare and everything else in their budget. And at the end of last episode, I told you this family represents 13,500 families in our region going through some version of this same experience. Today, we're going to zoom out and look at what that means. Because here's the thing, individual families experiencing underinsurance is a personal crisis, but 13,500 families experiencing it simultaneously, that's a regional economic emergency. And most of us have no idea it's happening. Let me give you the numbers. Southern Oregon has about 72,600 households. Of those, roughly 95% have some form of health insurance. We're actually doing pretty well on coverage rates. But among people with commercial insurance, that's employer-sponsored or individual market plans, 42% meet the clinical definition of underinsurance. That definition, established by the Commonwealth Fund and used in peer-reviewed research, out-of-pocket costs exceed 10% of household income, or deductibles exceed 5% of income. For lower-income households below 200% of the federal poverty level, the thresholds are even lower. Out-of-pocket costs exceeding 5% of income, or deductibles exceeding 3%. So, how many people are we talking about? Commercially insured individuals in Southern Oregon experiencing underinsurance. 84,400 people across 35,100 families. This is hitting hardest in the middle class, families who earn too much for Medicaid or meaningful subsidies, but not enough to absorb these costs without serious financial strain. And here's what really gets me. These aren't outliers. These are median numbers. The median out-of-pocket spending as a percentage of income for families earning $40,000 to $60,000, 14.2%. For families earning $60,000 to $75,000, 12.7%. These families are spending more on out-of-pocket healthcare costs than they spend on everything except rent. Now let's talk about who's leaving Southern Oregon and what we're losing. Between 2019 and 2024, Southern Oregon lost 3,400 working-age residents to net out migration. That's people aged 25 to 54 who left and didn't come back. We did post-relocation surveys. Not everyone responded, but we got 487 responses, about 14% response rate. Here's what they told us. Healthcare costs cited as the primary factor in their decision to leave, 28%. Healthcare costs cited as a significant contributing factor, 20%. Total healthcare influence departures, 48%. That's 1,632 people who left primarily or significantly because of healthcare costs. Now, who are these people? Ages 25 to 34. 38% of those who left. Ages 35 to 44. 41%. Ages 45 to 54, 21%. College degree or higher, 64%. Household income $50,000 to $100,000, 71%. Employed in healthcare, education, or tech, 47%. Families with children, 58%. Let me translate what that means. We're losing exactly the people Southern Oregon needs to retain. Prime working age, education credentials, middle income, the tax base, the consumer spending, the community investment, and families with children, school enrollment, youth sports, community stability, the economic impact of losing these people, lost wage income, $111.6 million annually. That's not total economic impact. That's just the wages these people would have earned and spent in our region. Lost consumer spending, $83.7 million annually. Lost state and local tax revenue, $9.6 million annually. Lost school enrollment, 1,703 students, representing $15.3 million in annual education funding from the state. And here's the thing, this is accelerating. If current trends continue, and there's no reason to think they won't, we'll lose another 4,250 working age adults between 2025 and 2029. Healthcare motivated portion, about 2,040 individuals. Lost annual wage income by 2029, $139.5 million. Cumulative economic drag from 2025 to 2029, $487 million. Think about that. Nearly $500 million in economic activity that won't happen in Southern Oregon because people can't afford healthcare here. Let me make this concrete with schools, because school enrollment affects everyone, even people without kids. In Oregon, schools are funded on a per-student basis. Lose students, lose funding. If the trend continues at its current rate into 2029, we're looking at an additional 2,400 students lost. That's 4,103 total students, or $36.9 million in annual funding. What does that actually mean? School consolidations, rural schools closing, fewer programs, arts, athletics, advanced courses all get cut when funding drops. Larger class sizes, teacher layoffs, districts competing for the same shrinking pool of educators. And here's the vicious cycle. Fewer programs and larger classes make schools less attractive to families, which means more families leave, which means more funding lost, which means more cuts. We're already seeing this. Now let me show you where healthcare money is going and why that matters for our regional economy. Healthcare spending that leaves Southern Oregon with no local economic multiplier effect. Specialty care out of region, $147 million annually. When Southern Oregonians have to go to Portland, Bend, or Eugene for specialized care, that's money spent on Portland hotels, Portland restaurants, Portland parking. Not here. Prescription drugs through pharmacy benefit managers, $89 million annually. PBMs are mostly out-of-state corporations. That's money leaving the region entirely. Insurance administrative costs, $276 million annually. National carriers with headquarters elsewhere. Claims processing in other states. Corporate profit extracted from our region. Total annual leakage, $512 million. $512 million that could potentially circulate in our local economy, supporting local jobs, generating local tax revenue, funding local investment, but instead leaves entirely. If we could retain even 30% of that through care delivery innovation, direct primary care, and administrative efficiency, that's $154 million in economic activity that stays local. That's equivalent to the entire annual payroll of Southern Oregon's 8th largest employer. So you might be asking, is this a national problem or is it specific to Southern Oregon? The answer is, it's worse here. Remember our representative family? They spent $15,862 on healthcare in 2024. that same family with the same income and the same health events would have spent. In Portland, $11,640. That's $4,222 less, or 27% lower. In Eugene, $12,580. That's $3,282 less, or 21% lower. National average, $12,180. That's $3,682 less, or 23% lower. Southern Oregon healthcare costs for this family are 21 to 37% higher than comparable markets, and this gap has widened by 34% since 2019. Why? Three main reasons. Carrier concentration. In Southern Oregon's small group market, that's employers with fewer than 100 employees, the market share breaks down like this. Pacific Source, 44%. Providence Health Plan, 34%. Regents, 16%. Moda, 6%. Two carriers, Pacific Source and Providence, control 78% of the market. Now, there's a measure economists use called the Herfindahl-Hirschman Index, or HHI. It measures market concentration. The Department of Justice uses it to evaluate whether markets are competitive. Here's how it works. HHI below 1,500, competitive market. HHI 1,500 to 2,500, moderately concentrated. HHI above 2,500, highly concentrated. Southern Oregon's small group health insurance market, HHI, approximately 3,480. That's highly concentrated. In antitrust terms, that means limited competition and potential for above-market pricing. Let me show you what this looks like compared to other markets. Portland Metro. Top two carriers, 58% market share. Number of viable carriers, 5. HHI, approximately 2,240, moderately concentrated. Eugene Springfield. Top two carriers, 63% market share. Number of viable carriers, 4. HHI, approximately 2,680, concentrated but less extreme. Southern Oregon is the most concentrated of these markets, and that concentration has consequences. And here's why concentration matters. When employers shop for insurance, they need alternatives. If you don't like your renewal offer, you need somewhere else to go. But in Southern Oregon, if you want a network that includes local providers, you're essentially choosing between Pacific Source and Providence. That's not a competitive market. That's a duopoly. And carriers know it. Now let's talk about the hospital side. Economic research is very clear on what happens when hospital systems control more than 60% of a market. They command 18 to 31% price premiums over competitive markets. They have 40 to 60% weaker correlation between price and quality, meaning higher prices don't necessarily mean better outcomes. Employer health plan cost increase 4 to 7% for every 10 percentage points of market concentration above 50%. Southern Oregon's hospital concentration penalty. We estimate $1,764 to $2,616 per family per year. Now, I want to be clear about something. This is not about hospital quality. Asante provides good clinical care. Providence provides good clinical care. This is about market power. When a hospital system knows that insurance carriers need them in the network because employers and patients demand access to local care, they have pricing leverage. And when there are no meaningful alternatives, that leverage becomes market power. Here's a concrete example. A knee replacement surgery. In Southern Oregon, the average negotiated rate, the price insurance actually pays, ranges from $38,000 to $68,000, depending on facility and contract. In Portland, with more hospital competition, that same procedure averages $32,000 to $48,000. Same procedure, same outcomes, but 19 to 42% higher cost in Southern Oregon. Multiply that across every procedure, every admission, every outpatient service, and you see why our healthcare costs are structurally higher. Now let's talk about why individual employers, especially small employers, can't solve these problems on their own. Employers with fewer than 100 employees face structural disadvantages in the health insurance market. Negotiating leverage. Large employers with 500 plus employees can negotiate aggressively with carriers. They can threaten to self-fund, they can demand data, they can walk away. Small employers, they accept the carrier's initial renewal offer 73% of the time. Why? Because they have limited time, limited expertise, and limited alternatives. The HR person at an 85 employee construction firm is also handling payroll, workers' comp, OSHA compliance, and hiring. They don't have time to become a health insurance expert. They don't have actuarial support. They don't know what's negotiable. Access to self-funding. Large employers often self-fund their health plans. They pay claims directly and use insurance only for stop-loss coverage against catastrophic claims. This gives them transparent pricing, control over plan design, and the ability to implement innovations like reference-based pricing or direct primary care. Small employers can't self-fund. The risk concentration is too high. If one employee has a $200,000 claim, it could bankrupt an 85-employee firm. So they're stuck in fully insured plans where the carrier controls everything and transparency is minimal. Broker sophistication. Large employers work with sophisticated consulting firms that provide data analytics, plan design expertise, and strategic advisory. Small employers work with local brokers whose primary business model is carrier commissions. The broker gets paid by the carrier, not the employer. So whose interests do you think they prioritize? Not all brokers. Some are excellent and truly advocate for their clients, but the structural incentive is misaligned. Data analytics capability. Large employers have dedicated benefits staff, actuaries, and consultants who analyze claims data, identify trends, and optimize plan design. Small employers get a one-page renewal summary showing last year's premium and this year's premium. No claims detail, no utilization patterns, no recommendations. The result, small employers pay more for worse coverage because they lack the leverage, expertise, and alternatives to negotiate better terms. And in Southern Oregon, where 78% of employers have fewer than 100 employees, this trap affects the majority of the workforce. So you might be asking, what has the state done about this? Oregon has actually tried several things. Let me walk through them and why they haven't solved the problem. Cost growth target, 2019. Oregon established a 3.4% annual cost growth target for healthcare spending. Sounds good, right? Except it has no enforcement mechanism. It's aspirational. Actual Southern Oregon cost growth 2020 to 2024, 8.4% annually. The target did nothing. Oregon Reinsurance Program 2018 provides reinsurance for individual market plans to reduce premiums. This has been effective, 22% premium reduction in the individual market. But it doesn't apply to employer-sponsored coverage. Our representative family gets zero benefit because they have employer insurance. Prescription Drug Price Transparency, 2018, requires drug manufacturers to report price increases exceeding certain thresholds. The reports get published, the press writes articles, and then nothing. There's no mechanism to actually control prices. Hospital Price Transparency, Federal Rule 2021. Hospitals must publish their negotiated rates with insurers. Compliance has been incomplete. And even when hospitals publish the data, it's complex, not consumer actionable, and doesn't prevent price increases. So what hasn't Oregon done? Authorize and support employer purchasing cooperatives. They're legal, but there's no state infrastructure to facilitate them. No technical assistance, no startup funding. Implement reference-based pricing for state employees. Oregon could use its own purchasing power to demonstrate that paying 150% or 180% of Medicare rates works. They haven't. Address hospital and carrier market concentration. No antitrust enforcement, no rate regulation, no public option to provide competitive pressure. There are bills being drafted for the 2026 legislative session. SB 1450, support for employer purchasing alliances. But as of now, the policy environment basically allows market concentration to continue unchecked. Here's the fundamental issue. Individual families cannot solve this. A family earning $62,000 cannot negotiate with Pacific Source. They can't tell Asante to charge less. They can't force their employer to offer better coverage. They're price takers, not price makers. Individual small employers cannot solve this either. An 85-employee firm has no leverage with carriers. They can't negotiate reference-based pricing with hospitals. Asante would just say, no. They're also price takers. Even individual large employers struggle. A 500-employee firm has some leverage, but not enough to transform the market. This is a collective action problem. It requires collective action solutions. That means employers pooling purchasing power to negotiate as one entity. Provider contracting based on value and transparency, not market power. Direct primary care integration that reduces specialist and hospital utilization. Reference-based pricing for surgical procedures. Policy support that enables these innovations. No individual employer can do all of that, but a coalition of 35 to 50 employers representing 2,000 to 3,500 covered lives, that changes the math. Let me show you what happens if we don't act. 5-year projection under status quo. By 2030, median family health care costs in Southern Oregon $25,990 annually. That's 35.6% of median income, up from 22.8% today. Median family deductible, $10,774, up from $7,000 today. Underinsured rate, 58% of commercially insured, up from 42% today. Households with medical debt, 34%, up from 19% today. Working age outmigration, 6,800 cumulative, double the 2019 to 2024 baseline. Lost annual wage income, $223.2 million, double current levels. School enrollment decline, 2,400 additional students lost. Regional economic drag, $487 million, cumulative 2025 to 2029. This is not speculation. This is compounding the documented trends from the past 5 years. Healthcare costs growing at 9% annually, while incomes grow at 3%. The gap widens every year until it becomes unsustainable. And we're already seeing the consequences. Families leaving, schools consolidating, employers struggling to recruit. The window to intervene proactively is narrow. In the next episode, our final episode, we're going to talk about exactly what that collective action looks like. Employer coalitions that pool purchasing power, direct primary care that reduces specialist referrals, reference-based pricing that saves on surgical procedures, pharmacy carve-outs that recover millions. We're going to show you the evidence from Wisconsin, Montana, Idaho, and rural Colorado, markets just like ours that have implemented these solutions and achieved 13 to 17% total cost reductions while lowering employee out-of-pocket costs by 30 to 40%. We're going to talk about the Southern Oregon Employer Coalition that's forming right now with a target launch date of January 2027. And we're going to tell you exactly what needs to happen to make it viable. Because this is solvable. The solutions exist. The evidence is strong. The timeline is defined. What remains is decision and action. That's next time. This podcast is for educational purposes only. I might get details wrong. If you catch errors or have alternative perspectives, please comment. Subscribe to our newsletter at reimagine-healthcare.org. Thanks for listening.